we present to you surgical management of complicated retinal detachment in a case of retinal hemangioblastoma. We assure that there is no financial interest in the making of the video and it is purely for academic purposes only. A 40-year-old male visited our Vitreoretina services with complaints of sudden onset diminution of vision in the left eye for 2 weeks. He first visited us 3 years back for a routine eye checkup and was diagnosed as a case of both eye retinal hemangioblastoma. He underwent 2 sittings of FFA-guided transpupillary thermotherapy in both eyes and has been under regular follow-up since then. He was asymptomatic with stable vision and stable retinal findings. On ophthalmic evaluation, the best corrected visual acuity in the right eye was 6/6 and in the left eye was counting fingers at 2 meters. Findings of the anterior segment evaluation were within normal limits. Fundus evaluation of the right eye showed multiple retinal hemangioblastomas. The lesions located superotemporally and inferonasally were inactive, but the lesion located inferotemporally was an active lesion with a feeding artery and a draining vein. Left eye fundus evaluation showed multiple active lesions with their feeding and draining vessels. We could also see multiple pockets of subretinal lipid exudation, serous retinal detachments, and pre-retinal vitreous membranes. Before taking the discussion further on, one should know a few facts on this condition. The retinal hemangioblastoma, previously known as retinal capillary hemangioma, is a benign vascular hematoma with dilated feeding artery and a draining vein. They may occur either as a hereditary lesion, as a part of von Hippel-Lindau syndrome, or as an isolated sporadic entity. They may occur as multifocal and bilateral lesions. Treatment of sight-threatening condition with retinal angioma can be challenging and is usually difficult to manage. In our case, keeping in mind the association with von Hippel-Lindau syndrome, a thorough systemic workup was planned. This included inquiry about family history, physical and neurological examination, serial blood pressure monitoring, routine blood test including serum catecholamine levels, abdominal ultrasound, and brain and spinal cord MRI. The patient gave no significant family history, but on serial blood pressure monitoring, it was found persistently high on many occasions. 24-hour serum vanillyl mandelic acid was also found raised, indicating towards presence of pheochromocytoma. Based on Danish and international VHL diagnostic criteria, we classified it as a case of VHL-associated retinal hemangioblastoma. Based on history, clinical evaluation, and systemic workup, a final diagnosis of left eye complicated retinal detachment in a case of VHL-associated retinal hemangioblastoma was made, and the patient was posted for surgery. The active lesion of the right eye was treated with single setting of transpupillary thermotherapy and subsequently followed up. Our surgical goal was to eliminate the tumor masses causing subretinal lipid deposits, exudative retinal detachment, and fibrovascular proliferation. We aimed to attain anatomical success as much as possible and to provide functional vision to the patient. Keeping our goals in mind, we made a surgical plan to perform a core vitrectomy, cauterize the feeder and the draining vessels, and excise the hemangioblastoma. We would try to peel the preretinal membranes as much as possible, and if it is found to be inadequate to relieve the anterior-posterior and tangential traction, circumferential peripheral retinectomy will be performed. This will be followed by perfluorocarbon liquid-assisted 360-degree retinopexy and finally silicone oil tamponade. As per our plan, surgery was scheduled under local anesthesia. A standard 3-port 23-gauge pars plana vitrectomy was initiated. Lensectomy was performed before core vitrectomy for adequate visualization and approach of peripheral retina and vitreous base. Since the lens was soft, it could be easily removed with a vitreous cutter. A core vitrectomy was performed with a cut rate of 7,500 cuts per minute and vacuum setting of 200 mm of mercury. pre-retinal membranes surrounding the hemangioblastoma was carefully scraped with the help of vitreous cutter. Forceps and membrane scrapers can also be used for this procedure. Meticulous manipulation of retinal hemangioblastoma is of prime importance in the surgery. Endodiathermy was applied on the feeding and the draining vessels to eliminate the chances of torrential hemorrhage. After cauterizing the major blood vessels, endodiathermy was applied circumlesionally to prevent bleed from the collateral channels. Relieving retinotomy was initiated and fashioned around the hemangioblastoma to free the lesion from the surrounding retinal tissues. Similarly, the lesion located inferonasally was also excised from the retinoschitic cavity. A 360-degree retinal cauterization was done to mark a perimeter before performing retinotomy. While performing cautery around the retinal hemangioblastoma, utmost care was taken. Even after taking maximum care, torrential hemorrhage occurred, which was most feared of. It happened to such an extent that it obscured the surgeon's view. With such a situation in place, intraocular pressure was raised above the central retinal artery pressure to have a tamponade effect, and the vitreous cutter was introduced near the point of hemorrhage to actively aspirate the blood. The bleeding was then allowed to slow down on its own. After completing the 360-degree retinal cauterization, circumferential peripheral retinotomy was initiated to relieve the anterior-posterior and tangential traction. Temporal free edge of retina was gently lifted, and the submacular proliferative membranes, lipid deposits, and debris were aspirated to facilitate the adequate retinal reattachment. Perfluorocarbon liquid was injected to flatten the retina. Multiple rows of near-confluent laser spots were applied to achieve complete retinochoroidal adhesion and prevent further regress of fluid into the submacular space. A 360-degree inspection was done to ensure that no retinotomy edge is left unlasered. Finally, the perfluorocarbon liquid was replaced with 1300 centistokes of silicone oil. Sclerotomies were closed with 7-0 vicryl suture. Patient was advised to maintain a face-down position for 2 weeks to gain maximum tamponade effect. Early postoperative period was uneventful with adequate anatomical success and no reopening of the cauterized blood vessels. After 8 weeks of surgery, satisfactory functional and anatomical outcomes could be achieved with a best corrected visual acuity of 6/36. Retina was attached with 360-degree firm retinochoroidal adhesion. Remnants of the retinal hemangioblastoma appeared to be inactive with regressed blood vessels, and no further treatment was advised. The take-home messages from this case discussion are: close follow-up, keen observation, and prompt treatment in the early stages of the disease is indispensable to prevent untoward sequelae of retinal hemangioblastoma. Surgery, if indicated, should be performed diligently and with careful handling of the blood vessels and anomalous tissue. Thank you.